Welcome to The Debate. So imagine you are sitting in your living room, right? And suddenly a blaring, ear-piercing security alarm just goes off.
Oh, instant panic. You immediately assume someone broke a window or something.
Exactly. You assume there's a physical intruder requiring this aggressive, immediate response. But, well, what if the alarm system itself is just short-circuiting?
Right.
What if there is no intruder? And taking a sledgehammer to the alarm panel to shut it up only causes, more structural damage to your house.
That is a highly destructive way to solve a wiring issue.
It is. And today, we are looking at what happens when that exact scenario, a blaring alarm that might just be a false signal, plays out inside the human face. Specifically, we're diving into the clinical and diagnostic conflict in urgent care surrounding severe, recurrent forehead pain and nasal symptoms.
Right, it's one of the most stressful clinical tensions in modern practice, honestly, largely because the stakes can escalate so rapidly.
They really can. So the central question we are exploring today is this. Should clinicians adhere strictly to a 10-day watchful waiting period because the overwhelming statistical likelihood is that these symptoms are neurogenic migraines or simple viruses?
Or on the flip side, should they embrace the 3 to 4 day early antibiotic intervention rule? And that's due to the severe anatomical risks of acute bacterial rhinosinusitis in the frontal sinus.
Exactly. And we are drawing this discourse directly from the 2026 Clinical Practice Guidelines, the Infectious Diseases Society of America, or IDSA guidelines, and some really fascinating recent neurological analyses.
Yeah, those analyses detail the intense physical overlap between cephalalgia, which are basically headaches, and true rhinosinusitis.
I lay my cards on the table first. I take a hard line on diagnostic skepticism and strict antibiotic stewardship here. We absolutely need a rigid 10-day waiting period because the data shows up to 90% of what patients self-diagnose as sinus headaches are actually migraines in disguise.
And I take the perspective of pragmatic, aggressive intervention. When a patient has a history of severe recurrent frontal sinusitis, early antibiotic therapy around day 3 or 4 isn't some overreaction. It is a required maneuver to prevent life-threatening intracranial complications.
Well, let me start by outlining what we are actually treating when a patient walks into a clinic complaining of intense forehead pressure. Aggressive antibiotic prescribing in the urgent care setting is, quite frankly, a massive failure of diagnostic precision.
A massive failure? That's a strong phrase.
I mean, I stand by it. We have robust, undeniable data showing that up to 90% of what patients report as sinus headaches perfectly meet the clinical diagnostic criteria for a migraine or a tension-type headache.
The mechanism here is the trigeminal autonomic reflex,
which is a fascinating neurological pathway, I agree, but it's often entirely misunderstood by both patients and clinicians.
Completely misunderstood. So let's break it down. The trigeminal nerve is the primary sensory nerve of the face, right? When a migraine activates this nerve, it triggers parasympathetic outflows.
Basically, signals sent directly to the mucous membranes of the nose and sinuses.
Right. And this results in cranial autonomic symptoms. The patient experiences clear, watery rhinorrhea, so a continuously running nose, along with profound nasal congestion and deep facial pressure. It perfectly mimics a sinus infection. It is an incredibly convincing disguise. I'll give you that.
Yet, we see clinicians broadly prescribing heavy antibiotics for this. The 2026 MIPS Quality Idea #331 measure, which is essentially a national quality metric used to grade physicians on whether they are overprescribing, was explicitly designed to combat this exact blind spot.
Because we know that 70% of acute sinusitis resolves entirely without antibiotics anyway.
Exactly. Treating a neurogenic headache with high-dose antibiotics is like using a chemical fire extinguisher on a holographic fire. It creates a toxic mess, leaving the patient at risk for C. diff or systemic antibiotic resistance without ever addressing the actual neurological short circuit that caused the pain in the first place.
I come at it from a different way, rooted heavily in the clinical reality of recurrent acute rhinosinusitis, or RARAS.
Okay, let's hear it.
While the phenomenon of migraine misdiagnosis you just described is absolutely real, I'm not denying that. Applying that strict 10-day rule as a blanket policy is dangerously misapplied when we are dealing with severe frontal presentations.
Dangerously misapplied?
Yes, because we cannot ignore the 2026 guideline exception. That exception clearly states that persistent, significant sinus pain for 3 to 4 days, accompanied by a high fever, and we are talking 102 degrees Fahrenheit or 39 degrees Celsius, along with purulent nasal discharge, mandates immediate antibiotic therapy. We have to respect the physical anatomy of the skull.
I completely agree we have to respect the anatomy. But how does the anatomy justify abandoning watchful waiting after only 72 hours?
Because the frontal sinus, if you put your finger right above your eyebrow, that hollow cavity inside the bone is not just another open airway. It is essentially a sealed box.
Right.
Aimed for being sieve-like, full of tiny holes for your olfactory nerves. More dangerously, that area contains a network of valveless diploic veins.
And those don't have the one-way flow, right?
Exactly. Typically, veins have one-way valves to keep blood flowing in one direction toward the heart. These veins do not. That means they are a two-way street. A bacterial infection in the frontal sinus can easily travel retrograde, riding the current backward directly into the cranial cavity.
Which is terrifying, obviously.
It's beyond terrifying. Delays in treating a true bacterial infection in this specific region carry an unacceptable risk for devastating complications. We are talking about orbital cellulitis, where the eye is threatened, or subperiosteal abscesses, or cavernous sinus thrombosis. We just don't have the luxury of waiting 10 days when a bacterial infection is practically knocking on the door of the central nervous system.
But this raises the immediate problem for the clinician sitting in the room with the patient, because the symptoms of neurogenic headaches and bacterial infections overlap so heavily. How do you actually separate the migraine disguise from a true bacterial threat?
Well, you have to look at the clinical markers.
Let's look closely at the neural olfactory pathways first. The sensory innervation of the sinuses is mediated by the ophthalmic, or V1, and maxillary, or V2, branches of the trigeminal nerve.
Right.
When these nerve branches are irritated, whether by a primary headache disorder or just a minor viral trigger, they release a cascade of neuropeptides.
Specifically, molecules like calcitonin gene-related peptide, or CGRP, and substance P.
Exactly. And for those trying to visualize this, think of CGRP and substance P as chemical flares. The nerve drops these flares into the facial tissue, causing localized neurogenic inflammation.
The blood vessels dilate, the tissue swells.
The local blood vessels dramatically dilate, the tissue aggressively swells, and the pain the patient feels is intense and localized. The patient is not lying. Their forehead pain and the visible swelling around their eyes are incredibly real.
But the mechanism is strictly neurological.
Yes, there is no bacterial pathogen driving the event. It's a physiological response to a neurological ghost, which means prescribing an antimicrobial agent to kill a non-existent bacteria is entirely useless.
I see why you think that, but let me give you a different perspective on what happens when a true pathogen is present. I am not disputing the existence of CGRP, or neurogenic inflammation.
Okay.
But true acute bacterial rhinosinusitis, or ABRS, can be distinctly and confidently identified by an astute clinician without waiting an arbitrary 10 days. The clinical markers of actual bacterial proliferation are highly specific if the clinician actually knows what to look for.
Such as?
We are not just looking at facial pressure. We are looking for the presence of thick, yellow or green, purulent discharge. That purulence is not just mucus. It is dense with neutrophils, dead white blood cells that act as the casualties of a localized bacterial war.
But, even viral infections can cause discolored mucus due to cellular debris.
Yes, but combined with other specific markers, the picture becomes clear. We are also looking for true anosmia, a significantly reduced or entirely absent sense of smell.
Right, not just a stuffy nose.
Exactly. This is a physical, mechanical blockade of the olfactory cleft by infected sludge. The nerve endings that detect smell are entirely walled off. This clinical picture is entirely different from the clear, watery discharge and the photophobia, sensitivity to light, or phonophobia that typically accompany a migraine.
I see the distinction you're making.
Furthermore, the absolute hallmark of secondary bacterial proliferation is the double sickening phenomenon.
You're referring to the biphasic illness pattern.
Right.
So the patient has a standard viral illness for the first few days. They begin to naturally improve. And then suddenly, around day 5 or 6, they experience a severe, rapid worsening of symptoms with a new high fever and intense localized pain.
And you see that as definitively bacterial?
That biphasic pattern is the clinical footprint of a bacterial opportunistic infection taking hold in the obstructed sinus cavity. The virus primed the environment, and the bacteria moved in.
I have to push back hard on that, actually, because relying on double sickening relies heavily on subjective patient reporting. And that is notoriously unreliable in an urgent care setting.
Unreliable? How so?
Well, how can a clinician empirically trust a patient's self-reported timeline of worsening symptoms or subjective feelings of fever and chills when a severe migraine attack also causes massive systemic feeling autonomic distress?
But a fever is measurable. Sometimes they don't tempt them right at the peak, or they took Tylenol. A patient in the throes of a severe migraine will often report feeling completely flushed, deeply nauseous, entirely wiped out, and they will vividly describe their pain as getting much worse over the last 24 hours.
Right.
They interpret their neurogenic response as an escalating infection. If we rely on subjective, double-sickening narratives, we are going to indiscriminately prescribe antibiotics to migraineurs who simply happen to be experiencing a severe attack a few days after catching a mild viral cold.
Okay, but if we assume the patient's subjective reporting is flawed, then the timeline becomes our primary diagnostic and triage tool. This brings the 10-day watchful waiting rule directly into conflict with the 3 to 4 day exception for severe presentations.
It does.
If we have a recurrent presentation, a patient who has a known history of anatomical susceptibility in their sinuses, waiting 10 days actively ignores the physical pathogenesis of bacterial biofilms and trapped purulents.
Walk me through the mechanics of that 3 to 4 day shift from your perspective. Why is waiting 10 days so detrimental if their immune system is working?
Because of how the osteometal complex, the drain pipes of the sinuses, functions. When a viral infection causes mucosal edema, those sinus ostia swell completely shut.
Right. Totally blocked.
The mucociliary clearance system, the microscopic brooms that sweep mucus out of your head, just fails. You now have a warm, dark, hypoxic, or low oxygen environment filled with stagnant mucus. It is the perfect incubator. Bacteria begin to proliferate, and crucially, they begin to form biofilms.
Which are incredibly difficult to treat.
Exactly. Think of a biofilm as a bacterial bunker made of slime. The longer those bacteria sit undisturbed, the thicker the walls of that bunker become, making them incredibly difficult for the immune system or future antibiotics to eradicate.
I get the visual, yeah.
When a patient shifts from localized forehead pain to presenting with a high fever and chills on day 4, we're witnessing a cytokine-mediated systemic inflammatory response. The body is recognizing a trapped, escalating bacterial load and is sounding the alarm systemically. At that point, immediate high-dose amoxicillin clavulate is the only way to break the cycle before the biofilm becomes impenetrable or the infection breaches the bone into the brain.
I'm not convinced by that line of reasoning because it completely ignores the statistical realities of antimicrobial stewardship that must govern population health.
You're going back to the numbers.
Let's look at the actual numbers. Even if we can see that a secondary bacterial infection is present, and it isn't just trapped viral mucus or a migraine, the number needed to treat, or NNT, for antibiotics in acute sinusitis is between 11 and 15.
Which means you have to treat 11 to 15 people to see one benefit.
Right. For the listeners, the number needed to treat is a critical concept in evidence-based medicine. It means that you have to give up to 15 patients broad-spectrum antibiotics for just one single patient to experience a faster resolution of symptoms than they would have through their own spontaneous immune clearance.
Right. The rest clear it on their own anyway.
Exactly. The vast majority of these patients receive absolutely no clinical benefit from their drug. You are effectively failing 14 out of 15 patients by giving them a medication that does nothing to change their clinical outcome.
But those patients do receive the unmeasured benefit of preventing intracranial extension.
But at what cost? Let me ask you directly. How do you justify exposing patients to a number needed to harm of 8?
That is a high NNH, I acknowledge that.
For every 8 patients you treat with these heavy antibiotics based on just 3 or 4 days of symptoms, 1 patient will suffer a documented severe adverse effect. We are talking about profound gastrointestinal distress, Clostridial difficile or C. diff infections, or debilitating yeast infections.
I'm not dismissing those risks.
You are trading a theoretical, exceedingly rare anatomical complication for a guaranteed highly prevalent systemic harm. And you are doing it for symptoms that, statistically speaking, are still highly likely to resolve spontaneously by day 7.
That's a compelling argument. But have you considered the rapidly shifting microbiological landscape of these recurrent cases?
What do you mean?
When intervention is ultimately deemed necessary because the patient is failing to clear the infection, the pharmacological weapons we choose carry their own massive systemic risks, forcing a real debate over the safety of our most potent treatments. We are no longer dealing with simple, easily eradicated bacteria. In recurrent acute rhinosinusitis, the pathogens have adapted brilliantly.
You're talking about the rise in resistance rates.
Exactly. We are seeing Streptococcus pneumoniae with a 25 to 40% penicillin resistance rate simply due to alterations in their penicillin-binding proteins. To put it simply, the bacteria have changed the physical locks on their doors, so standard penicillin can't even bind to them.
Wow.
We are also dealing with Moraxella catarrhalis and Haemophilus influenza, where massive percentages of the isolates are beta-lactamase producers. They literally produce an enzyme that acts like molecular scissors, cutting the amoxicillin to pieces before it can work.
They just eat it for breakfast.
Exactly. They eat it for breakfast. This is why aggressive protocols are absolutely required on day 3 or 4 of a severe presentation. We have to defend the use of high-dose augmentin, which includes clavulanate, to distract those molecular scissors and overcome the resistance.
But sometimes even that isn't enough, right?
Right, and in severe, recurrent, or deep-pocket infections where anaerobic bacteria are suspected, we must escalate to specific combinations, like clindamycin paired with a third-generation cephalosporin, like cifixime. Clindamycin forcefully covers the anaerobes and gram-positives, while the cephalosporin provides the necessary gram-negative coverage. You simply cannot timidly approach a highly resistant, biofilm-protected infection sitting millimeters from the brain with a wait-and-see attitude.
And this is exactly where the compounding dangers of modern urgent care prescribing spiral completely out of control.
Out of control?
Yes, because not only are we dropping heavy microbiome-destroying regimens like clindamycin and cifixime on a diagnostic hunch, but clinicians are frequently doing it alongside systemic corticosteroid bursts.
Well, the patients are in agony.
Right. Patients come in and demand the steroid shots or the 5-day prednisone taper because they want the pain gone today. But prescribing a systemic steroid burst alongside heavy antibiotics for a 4-day symptom duration is medically contradictory.
See, I would argue the systemic steroids rapidly reduce the massive mucosal edema. They physically force open the ostia. If the sinus is completely blocked, the antibiotics circulating in the blood cannot penetrate the swollen tissue effectively to reach the trapped mucus. The oral steroid forces the pathway open so the antibiotics can actually do their jobs.
I have to stop you there, because the analogy I often hear clinicians use is that an oral steroid acts like a precision pharmacological surgical knife. It absolutely does not.
It's a blunt instrument, sure, but it works.
Using a systemic oral steroid like prednisone here is like dropping a massive water balloon on a swollen wooden door frame, just so you can force the door open. Sure, the door eventually opens, but you cause massive water damage everywhere else in the house.
That's a bit dramatic.
It's accurate. Even in short courses of 5 days or less, oral corticosteroids carry severe, widespread systemic risks. You are causing temporary but profound immune suppression.
The immune suppression is brief.
But it happens at the exact moment the body needs its immune system the most. You are artificially masking the pain while suppressing the patient's innate cellular immune response. You're disabling the very macrophages and neutrophils needed to fight the actual pathogen you claim is so dangerous.
The antibiotics handle the pathogen.
Furthermore, you are inducing rapid hyperglycemia.
You give a 5-day prednisone taper to a pre-diabetic patient or someone with metabolic syndrome, and their blood sugar shoots to 300. You've traded a sinus ache for a metabolic crisis. You also run the risk of severe psychiatric disturbances, from deep insomnia to severe mood volatility.
So what is your alternative when a patient's frontal sinus is completely obstructed, they are in absolute agony, and they have a 102-degree fever?
Instead of systemic steroids, we should be advocating strongly for topical intranasal corticosteroids, or INCS, combined with high-volume saline irrigation.
Topical sprays?
Yes, saline physically flushes the antigens and thins the mucus, while the intranasal steroid acts locally directly on the inflamed mucosa. There is virtually zero systemic absorption. We achieve the localized goal of opening the ostia, opening the doors, without disabling the patient's systemic immune system or disrupting their endocrine function.
I completely agree that intranasal steroids and saline are unparalleled for long-term maintenance and prevention, but when a patient is in an acute crisis, the mucosal swelling is so profoundly severe that topical sprays physically cannot even reach the middle meatus or the frontal recess.
You don't think they penetrate far enough?
They don't. The tissue is simply too engorged. The spray hits a wall of swollen tissue at the front of the nose and drips right back out. In those specific severe cases, a short systemic steroid is the only tool powerful enough to break the initial obstruction.
Well, I think we have clearly mapped out the edges of this conflict today. To summarize my position, it is an absolute necessity to maintain rigorous diagnostic skepticism in the urgent care setting.
Right.
Successfully distinguishing a neurogenic migraine and a viral rhinosinusitis from a true bacterial infection is paramount. The 10-day watchful waiting period is our strongest, most evidence-based tool to protect population health from the looming, very real crisis of antibiotic resistance. Furthermore, it shields individual patients from the profound, statistically guaranteed harms of adverse drug reactions and unnecessary systemic steroid exposure.
And to summarize my stance, while antimicrobial stewardship is undeniably vital for population health, clinicians must treat the actual, suffering patients sitting in front of them.
Of course.
Recurrent frontal sinus pain, accompanied by systemic markers such as a high fever and purulence, demands swift, aggressive, and appropriately escalated therapy by day 3 or 4. The unyielding anatomical reality of a sealed box infection resting directly on the paper-thin cribriform plate means that rigid, dogmatic adherence to a 10-day waiting period can invite dire, life-altering neurological consequences.
I think one major area where our perspectives certainly converge, and this is drawn directly and unambiguously from the 2026 guidelines, is the absolute uselessness of lab testing in this specific urgent care scenario.
Oh, absolutely, 100%.
We both firmly agree that ordering throat cultures and blood cultures is entirely non-contributory and essentially a massive waste of resources for uncomplicated rhinosinusitis.
Precisely. Throat cultures merely sample superficial colonizers in the pharynx. They tell you absolutely nothing about the deep pathogens trapped in the sinus cavities. And blood cultures are only relevant if the patient is in systemic sepsis, which is a completely different clinical entity entirely.
Right.
We are entirely reliant on clinical pattern recognition. There is no rapid blood test or simple swab that will make this diagnostic decision for us. It requires a clinician who deeply understands the nuanced interplay of trigeminal symptoms, cranial anatomy, and pathological timelines.
The intricate complexity of the trigeminal nerve pathways, combined with the paranasal sinus anatomy, ensures that this will undoubtedly remain one of the most challenging, high-stakes diagnostic presentations in everyday medicine. There's certainly much more to explore in the source material regarding the long-term surgical management of chronic rhinosinusitis and our rapidly evolving understanding of neurogenic headache disorders.
The line between patiently waiting and aggressively intervening is razor thin. And as the microbiology continues to adapt and evolve, our diagnostic frameworks are going to have to adapt right alongside it.
Ultimately, it brings us right back to that blaring security alarm system in the living room. Is it a true breach of the perimeter requiring a heavy, immediate intervention? Or is the intricate wiring of the nervous system simply sending a false, terrifying signal? We leave it to you, the listener, to weigh the evidence, consider the anatomy, and form your own conclusion on exactly where to draw the line. Thank you for joining us.